Hello and welcome to PBS Updates, a new short series from the Oncology podcast where we break down the latest changes to Australia's pharmaceutical benefits scheme and what they mean for oncology practice. This is Rachael Babin from the Oncology Network, and I'm joined by Professor Craig Underhill. In this series, we take a quick look at the recent oncology and haematology updates, what's changed, which patients may benefit, and what clinicians should know. For more detail and ongoing coverage of cancer medicines, you can also visit oncologynetwork.com.au. So, if you want a fast, practical overview of the latest PBS developments, you're in the right place. Let's get into it.
G'day. Welcome to PBS Update for May 2026. I can see you. People will only be able to hear you, but it's lovely to be here with Rachael Babin.
Thank you, Craig. It's nice to be back with you again. Third episode in our new series. So thanks to all the listeners for tuning in.
Yeah, we've been really pleased with the volume, the number of listeners to date, Rachael. It's been really pleasing to see, and we've had some nice feedback. And so it's a bit of a niche podcast, but serving a bit of a gap for people who are wanting to sort of keep across new drug developments, and would also encourage anyone listening from pharma, if they want to let us know about new drug access programs, we can also mention those on subsequent episodes. But let's get into it. We had a whole heap in April. There was quite a number of listings, including some new haematological listings. We've got a couple of those today, but one new medical oncology drug. Do you want to have a go at saying the name of this drug before I civil it, Rachel?
It's my turn this week. I'm going to go with fruquintinib.
Yeah, well done. I think that's very right. Fruquintinib. So this is a VEGF inhibitor in metastatic colorectal cancer. It's been approved now on the PBS. It's really a fourth-line treatment. So according to the listing, patients need to have previously received both oxaliplatin, irinotecan, and fluoropyrimidine, an antivascular endothelial growth factor agent or anti-VEGF inhibitor, and also an anti-EGFR agent if they're a KRAS wild-type tumour. So it's interesting. This listing is based on a study called FRESCO-2, and interestingly, the patient population in that study was slightly different to the previous listing. So as well as having failed a fluoropyrimidine, oxaliplatin, irinotecan, anti-VEGF, anti-EGFR, RAS wild type, they also had to have disease progression or be intolerant to trifluridine tipiracil, whose brand name's Lonsurf in Australia, or regorafenib. So interestingly, the PBS listing doesn't require that progression on the Lonsurf. And interestingly also, the PBS changed the restriction to trifluridine tipiracil or Lonsurf at the same time in May. So I know we couldn't work out what historically the difference was between those two listings, but these two drugs are now available in the same population. So it's people basically having third or fourth line treatment, depending on whether they'd had those other drugs in combination or not. It's an oral agent, 5 milligram tablet for 21 days of a 28-day cycle. And the information in the study showed a median overall survival of 7.4 months in the fruquintinib group versus 4.8 months in placebo, has a ratio of 0.66, so reducing the risk of death by a third. The disease control rate was said to be 56% in the fruquinitinib group versus 16% in the placebo group, and the median duration of response 10 months. The patients who responded for a reasonable amount of time. So the questions always is, for that additional few months of survival, is it worthwhile? What are the side effects? And so in the fruquinitinib group, any grade 3 toxicity was in 2/3 of patients, 63%. So this is grade 3 or 4, people being admitted to hospital. Then the individual side effects of interest included hypertension. So grade 3 hypertension, 14%. That's quite a high rate. We don't often see that with other drugs, and it's actually recommended that when patients are started on the treatment, they have a weekly blood pressure monitoring through the first month. Abnormal liver function was another adverse event of interest, and 18% rate of proteinuria, and so again, it's recommended that should be tested for while patients are on treatment. 2% grade 3. So 63% of the grade 3 toxicity in the placebo group, 50% of those had grade 3 toxicity. Even patients on placebo have some of these measurable adverse events. So I haven't personally used this drug as yet, but I have seen in some chat groups some comments that there is demonstrable toxicity in these patients that need to be managed, and some patients do have a tough time and need to come off drug. So again, in an individual patient, it's having a discussion about embarking on this treatment and then managing the toxicity or taking them off treatment if the toxicity is unacceptable or not manageable. So I did notice that this drug had been given a score on the EBIQ website for the ESMO magnitude of clinical benefit scale and gave it a score of 3 out of a maximum of 5, where 4 and 5 represent scores with substantial benefit. So it's sort of in the middle. Mm-hmm. So it is an option for patients fourth line if they're not eligible for clinical trials or other treatments. It has been recommended on the NCCN and ESMO guidelines as well, which is good to know, but it's an individual discussion and adjustment, an individual patient with their treating medical oncologist.
Yes, of course. As the health minister said, this is the update he highlighted this month. It is about giving stage 4 patients another option to potentially extend their lives, but also highlighting that prognosis is not good. There are limited options. The information that you've just provided is really helpful. So just be aware of the guidelines, and a careful approach will be required with toxicity management.
Exactly.
But good to see.
Yeah,
see exactly. These changes.
And of note, this is going to cost the patients the same, but it's actually slightly more expensive than the trifluridine tipiracil treatment, according to the PBS data. And I think they said about 800 people a year are likely to access the drug. All right, so there you go. So a new option in colorectal cancer. And then a couple of interesting ones in haematology. Firstly, there's epcoritamab, which is a CD3/CD20 bispecific antibody, and that's now on the PBS for relapsed or refractory diffuse large B-cell lymphoma. And that, again, patients needed to have failed a number of lines of therapy, including a relapse. They have to be relapsed or refractory to at least 2 prior systemic therapies, and also have failed CAR T-cell or been unable to receive CAR T-cell treatment and not eligible for a stem cell transplant. So again, another treatment option for the haematologists who are treating people with relapsed or refractory diffuse large cell B-cell lymphoma.
Fantastic. Thank you.
And it kind of segues a little bit into another interesting drug that's been listed in the haematology space. So this drug was listed on the basis of the EPCOR NHL1 study published in Lancet Haematology in 2024. It was a phase 1/2 study done in patients with relapsed or refractory lymphomas. And there was some sites in Australia that participated in that multi-centre international trial. The epcoritamab was on the basis of data from the EPCOR NHL1 trial. So there was a 2-year follow-up published in Leukemia last year in September. And so in this study, the overall response rate in patients with relapsed refractory diffuse large cell B-cell lymphoma was 63%, complete response rate of 40%, and estimated 24-month progression-free survival, overall survival were 27 and 44% respectively. And they estimated 64% of complete responders remain in CR at 24 months. So some what they call deep and durable responses in these patients. Looks like a very active drug, and no doubt there'll be other studies going on in earlier lines of treatment to look at activity, this drug. While we stay in the haematology space, it was very interesting listing this month. It was been announced in the media in the last couple of days. Interestingly, on the PBS newsletter that came out on 1st of May, this was not listed. So this drug is called Cilta-cel is a short name. Brand name is Carvykti, and it's ciltacabtagene autoleucel. Ciltacabtagene autoleucel.
Well done.
So this is the fourth drug to be listed for use in Australia. But as far as I'm aware, this is the first one actually listed on the PBS. So the other three drugs were listed through a different mechanism under the National Health Reform Agreement rather than on the standard PBS listing. So this seems to be the first one that the company producing the drug, Johnson & Johnson, and the Australian government have come to an agreement and are funding the drug on the PBS. The first patients are already receiving it at Peter MacCallum Cancer Centre and Alfred Hospital in Melbourne, and then it's expected to be rolled out to other centres in Australia. So this is for relapsed refractory multiple myeloma. Patients had to have at least 4 prior lines of therapy, so these are heavily pre-treated patients. This listing's on the basis of the CARTITUDE-1 study. So that's been first published in 2021. It's phase 1b/2 study, and then there was an update in 2023. And then finally, the 5-year follow-up data has been published in JCO in September 2025. So again, this group of heavily pre-treated patients was median follow-up of 61 months. For the 97 patients treated, the median overall survival was 60.7 months. So 1/3 of patients remain alive and progression-free for more than 5 years after a single infusion without maintenance treatment. 12 of the patients treated at a single centre underwent serial minimal residual disease and PET assessments, and all of those, 100%, were MRD negative at 5 years. So clearly, if you look at the whole group of 97 patients, median overall survival 60 months, progression-free survival in about 1/3 at 5 years.
So why do you think it took so long to see this new listing?
Oh, I think because we only had that long-term data, and probably because of the cost.
On the fight.
It was knocked back a couple of times by MSAC. So this MSAC, rather than the PBAC, looks at the data, was knocked back a couple of times, was approved late last year, and it's obviously been under negotiation between the company and the government and now been listed this month. So for these patients who are heavily pre-treated with little other options apart from clinical trials, this offers really great hope. This, as I said, this is now the fourth drug listed. And just to remind people about CAR T cells, how does that all happen? So for those not working in the hematology space, these are genetically modified T cells. So patient undergoes apheresis, so T cells are collected off, extracted from the patient's blood. They're engineered in the laboratory. Basically, a virus is used to introduce a new gene into the T cells, which instructs the cells to produce special receptors or CARs on the surface. These are then multiplied, expanded in the lab, reinfused back into the patient after intensive chemotherapy. The CAR T cells then recognize and bind to antigens on the surface of in this case, the myeloma cells. So this is a type of engineered immunotherapy specific to the patient. So they're using the patient's own cells to engineer the T cells, modify them. So it's pretty science fiction-y, isn't it, Rachel? I can see the raised eyebrows.
We're living in the Star Trek medicine era.
Yeah. So it's offering great hope, but it obviously has to be delivered in specialised centres. Virtually all the patients get a cytokine release syndrome and needed to be treated, managed. It's really a new field, but these cellular therapies seem to be offering hope, mostly in the haematological malignancies, but we're starting to see some trials done in some solid tumours as well. There's also 3 other products available listed under that different mechanism under the National Health Reform Agreement. and they're in children, young adults with B-cell precursor ALL, adults with relapsed refractory diffuse B-cell lymphoma, in follicular lymphoma, and in relapsed refractory mantle cell lymphoma. So specifically in some of these hematological malignancies.
Excellent. Succinct as ever. Thank you, Professor Underhill. And we will be hearing from you again soon. We have a new episode of the Oncology Journal Club out soon as well. So keep your ears open for that one.
We will. And as I said at the start, we're welcome to list compassionate access schemes. It's often quite hard for people to keep up with what's going on there. And those who are wanting to see other cancer drug news in between these episodes, jump onto the oncologynetwork.com.au and have a look in the industry spotlight section.
Yes, and you'll find the show notes there as well. So with links to more detailed updates if you'd like to delve a bit deeper. So thank you very much.
Fantastic, Rachel. And as ever, though, people need to make up their own minds. And here's our disclaimer. Please don't take what we say at face value. Please do your own research, do your own due diligence, check the drug indication, be across the efficacy and toxicity data, discuss it with your patients before embarking on prescribing any of these bloody difficult to say drugs.
Thank you.
Bye for now.
Bye, Craig. See you next month. That's all for this episode of PBS Updates. For more information on the listings we discussed and for ongoing coverage of cancer medicines, visit oncologynetwork.com.au, where you'll find news, analysis, and resources for oncology professionals. If you're working in industry and have details of compassionate access schemes or upcoming PBS changes you'd like us to share with the oncology community, feel free to get in touch. And don't forget to check out the Oncology Journal Club podcast if you'd like to hear more analysis and pearls of wisdom from Professor Craig Underhill. This podcast is proudly produced by the Oncology Network. Thanks for listening.